Carbon monoxide is colorless, odorless, tasteless, and non-irritating gas. It is slightly lighter than air and usually the product of incomplete combustion of carbonaceous fuel. We can't sense them, so it can be a silent killer. How does it work? So the first thing that we need to know is that hemoglobin binding. Carbon monoxide can bind hemoglobin with 250 times greater affinity than oxygen, causing COHB, and it reduces O2 carrying capacity and shift oxygen hemoglobin dissociation curve to the left, so that the compound is bind to hemoglobin and not go into the tissues. It can also bind to myoglobin, which can cause direct effect to cardiac and skeletal muscle toxicity. In terms of half-life, at the room air, it can take about 300 minutes. So that's a long time. But if we give 100% oxygen, it is clear in about 80 minutes. If we give hyperbaric oxygen, it is even quicker in about 23 minutes. So that is good. And elimination is purely through exhalation. Clinical features: COHB is correlating with symptoms. However, it is not complete. It depends on the duration of exposure, activity level, and individual susceptibility. So when the CO is less than 10%, usually it is asymptomatic in healthy people. There may be exertional dyspnea in people with underlying coronary artery disease. Even some of the heavy smokers may already have about that. If the level is going up to 20%, there will be frontal throbbing headache, like mild exertional dyspnea. And if it is going up to about 30%, the severity of headache is stronger. And there may be visual disturbance, impaired judgment. Cognitive impairment may be detected clinically. If it is 30 to 40, it may be confusion, syncope, tachycardia, and tachypnea, and high chance or risk of collapse and danger to the life. If it is over 40 to 50%, it is life-threatening and can cause cardiorespiratory failure, coma, or seizures. Over 60 is likely to lead to death. People who had CO poisoning or people with long-term CO exposure may experience delayed neuropsychiatric syndrome or DNS, and that is in 10 to 40% of severe CO poisoning. It may appear from 2 days to up to 40 days after initial apparent recovery. Symptoms may include cognitive impairment, SNLD, and behavioral changes, Parkinsonism, dementia, or psychosis-like symptoms. MRI scan may show white matter changes and basal ganglia lesions. However, it is hard to tell if someone has pre-existing condition or not. From the occupational fitness point of view, it tells us that we need to review them after the initial period of recovery. So when we are looking at the population, workers with coronary artery disease, pregnant, or workers with anemia, COPD, or hemoglobinopathy are more susceptible, and also those working at altitudes. Sources of carbon monoxide may include internal combustion engine like forklift, generators, compressor, petrol power tools such as concrete saw, high pressure washers, furnaces, kilns, smelting operations, welding, especially in the confined space, fire and rescue operations, and faulty gas appliances such as commercial kitchens and heating system. Therefore, some of the industries such as mining, firefighting, warehousing, automotive repair, steel or aluminum smelting, commercial kitchens, and construction workers, gas fitting and tunneling may have increased risk. From regulatory standpoint, Australia workplace exposure limit is 30 ppm, and starting from December this year, it will be 20. And rationale for 30 ppm TWA is that maintenance of COHB below 5% is required to protect workers with subclinical CAD and pregnant workers from adverse fetal effects. When we are diagnosing people with CO poisoning, we have to measure with co-oximetry, which is a device that can measure carboxyhemoglobin level, and standard pulse oximetry is unreliable. Arterial blood gas, if you can perform, show normal PaO2, but O2 content can be seen. On the ECG, there may be ST changes and arrhythmia. Troponin can be checked if we suspect any myocardial injury. Acute management scenario will be like a worker enter into a confined space or work in an area with very poor ventilation and sudden collapse. So what do? So we need to remove them, but we need to make sure the rescuer are safe and wearing SCBAs before attempting to rescue people from the collapsed area. And once they are removed, we need to look at make sure the airway open if they are not breathing, and then we may need to do CPR right away, but also give high flow oxygen. If we have access, we can give hyperbaric oxygen, but that's more likely to happen in the tertiary center. And we'll give fluids, and if this is in a shock, we will need to provide with the resuscitation. So once someone got recovered from that scenario, we will need to look at any residual symptom, in particular to the delayed neurological symptoms. From the control point of view, the elimination, substitution, engineering, administration have fairly similar to other dangerous gases. With PPE, standard P2 masks do not protect against CO, which should be reasonable since it is a gas and not particulate. And there are a few different questions that are asked about CO previously. However, one of the scenario we can think about is that we have a large warehouse company and 3 forklift operators present to the first aid room over a 2-hour period with headache, nausea, and dizziness. The warehouse used LPG powered forklifts and the roller doors has been closed due to heavy rain outside. Atmospheric monitoring shows CO level of 85 ppm in the main warehouse. That seems like quite high. So you can think about what to do in that scenario, and from the workers, from the system, and from the ongoing control perspective. Another scenario is that I had seen that similar question in the old questions before. 2 years old pregnant worker, 28 weeks gestation, as a commercial kitchen hand, and she attends a clinic concerned about CO exposure from multiple gas burners in a poorly ventilated kitchen. She reported that she experienced intermittent headaches and fatigue over 4 weeks. And all hygiene assessments show 8-hour TWA CO of 28 ppm in the kitchen. How do you approach from there? So these are potential scenarios you may experience in the written and the OSCE or clinical exams at A Form Stage B. Good luck.